My name is Ravi Mehta. I'm a nephrologist at University of California, San Diego, and it's both an honor and a privilege to be not only a chairperson for this session, but also the first speaker. And I have a tough task ahead because I have to keep myself on time to allow the other speakers enough time. So please bear with me. I will try and share with you an update of an initiative that we have started through the International Society of Nephrology in 2015 and give you a perspective of why this is an important area for us to be thinking about. This is my disclosure information. There are no conflicts with relationship to this presentation. Just to put this in perspective, we know that acute kidney injury is a major global healthcare problem with almost 13 million people afflicted with this in a year. And when you look at the number of deaths from acute kidney injury, it is quite staggering at about 1.7 million deaths in this group. And what's most important is that it comes with a very high cost. If you just put a monetary figure on it, in the United States, we spend $9 billion a year on acute kidney injury. It contributes to a lot more in terms of deaths, and you can see the combined mortality rate for all of these diseases like prostate cancer, breast cancer, heart failure, and diabetes are under the overall death rates of AKI. And then the costs are escalated by the length of stay in the hospital setting. And this is a cartoon which is modified from Mink Chawla's very nice paper, and we published in Kidney International, showing that if you look at the developed world with about 1 billion people, and you went through the sequence of AKI, approximately 10 to 15% mortality, 10% end-stage renal disease, and 20% CKD. So there's a big societal burden from this disease as you go on. And when you reflect that in the low and low-middle income countries, it is even higher in that setting. But yet we know from multiple experiences in our daily lives that there is an opportunity to prevent and treat this disorder if we have an earlier intervention, and both for recognition aspect. And when you think about how we have come about this knowledge, it is from multiple studies, both looking at clinical observation, interventions across the world itself. A meta-analysis was published about 3 years ago in CJASN, which looked at the KDIGO classification equivalents of acute kidney injury around the world. And you can see it is quite interesting that almost about 20 to 25% of patients in these meta-analysis had AKI, but we were lacking information from a large segment of the world, which is in Africa. So as part of the 0 by 25 initiative, which I'll explain in just a minute, a meta-analysis was redone, and with the literature all the way up till 2014. And you can see now that even with this, we have much better information set, which reflects that even in Africa and parts of Asia, there is a very high incidence of acute kidney injury itself. So one of the things which is important to realize is that this disease process afflicts all ages, all types of patients, all settings. There is nobody who is excluded. It does not discriminate. And as a reflection of that, you can see here is that the pediatric population, which is afflicted with acute kidney injury, a group which would not necessarily have the same comorbidities, is also particularly high. And when you look at the number of deaths in this situation, you can see that the death rates are also pretty high overall. So that led us to reflect overall in terms of why would we think about this as a global problem. When we look at high-income countries versus low and middle-income countries, the etiology and the settings are different. However, the net result is the same. So it doesn't matter where you are, it doesn't matter which sequence you're in, but you have, despite the different etiologies, the same consequences from this itself. So in 2013, Beppe Ramuzzi, who was the president of the ISN, stated in his presidential address for the ISN that he would like to propose a project 0 by 25, which would be that by 2025, could we eliminate preventable deaths from acute kidney injury worldwide? Now, in order to put this in perspective, one has to think about what is a preventable death. And so there are three types. One would be obviously the type 1, where you have environmental issues which contribute to acute kidney injury. And you can see these would be settings where, for example, you've got lack of clean water, you've got lack of basic infrastructure. A type 2 is something which we encounter every day in our lives, where we are contributing to it with iatrogenic or missed opportunities for recognition or treatment itself. And then a type 3 would be where there's an inadequate access to care or to dialysis or to lab studies for even major things, for simple things like hyperkalemia. And how this plays out is, if you think about the world and you were to think and divide countries in terms of different levels based upon the infrastructure and access to care, you could see that there will be some countries where preventable deaths are relatively few because they have access to most care. Take the United States, for example, or United Kingdom, for example. But even in these countries, and you take UK, for example, there's a huge opportunity for reducing mortality in acute kidney injury. And you take in contrast a level 3 country like Cambodia or, say, sub-Saharan Africa, where access to care is not given, and that even if you could afford care, you may not be able to get it. In those countries, the implications for this type of initiative are very different in that setting. So in order to appreciate the scope of this project, we defined it into 3 broad constructs. We needed to obviously collect the evidence and then raise awareness of AKI worldwide. And then third, implement some action items to be able to manage the change in this process. Now, when you think about how best to do this, we defined it as a 5R approach. So you could take acute kidney injury and divide it into 5 settings. Risk assessment, you could have the recognition, the response, and then renal support and rehabilitation. And these therefore become the 5 pillars around which this project is aligned and allows us also to identify and contribute accordingly to this. Now, collecting the evidence here was based upon a global snapshot where they had more than 300 participating centers, and we presented these data at World Congress, so I'll share you the essence of this data and what this started out at. The objectives were, could we go out and ask people in their daily lives that how many patients of AKI they encountered, what type of patients they were, and then what happened to these patients in the course of 1 week after they had been seen. So the design of this study was to look at patients. We asked physicians across the world to volunteer their effort. We provided a web-based database in which patients were entered information in. Physicians were asked to select one day in the period of September 29 to December 7th, 2014. And they selected that day one day, and on that day, every patient who met the criteria for AKI was enrolled and entered into the study database. And then we asked the question, what happened to them? The recognition of AKI was based upon suspicion, based upon signs and symptoms, and then we confirmed it with a test. So it was either a creatinine or a urine output. And here we modified the criteria to include those patients who had a decrease in creatinine, not only just an increase overall. So as you can see from this design, physicians picked their own index day. They decided which day they were going to enter the data in. They looked and they knew which day they were going to enter data in, so they started screening patients up to 3 days before. And then if on that day patients met AKI or they suspected an AKI, they had confirmation, they entered the information on that patient and then recorded the outcomes at 7 days later. We also asked them to record the number of overall patients they were seeing. So let's say if they were seeing 20 patients on that day, and 5 of them met AKI, then they recorded 20 patients overall and 5 met AKI. So we tried to get an idea of what the denominator was. And the confirmation was based upon a combination of symptoms, lab confirmation, and then they were enrolled. We tracked their dialysis requirement, we tracked renal recovery, and we also tracked survival at last observation, 7 days post-AKI and hospital discharge. we asked people to record information of both hospital and community-acquired acute kidney injury. And in order to present this data, we looked at the World Bank classification of gross national income. And as you can see here, there are 4 categories, and every country in the world is placed in one of these categories. Now recognize that this is an aggregate category. So in a particular country, you may have a region which is very poor, and you may have a region which is very afforded and has very rich access to care. But for that one country, it will be placed into one of these categories itself. And this is sort of our starting point. So about 27,000 patients were screened, and it may not reflect the total number screened because not every physician put in the information. Out of these 27,000 patients, we have this spread of about 4,000 patients who are enrolled, and this is the distribution across the different sets overall, and what happened to these patients. 322 physicians, 72 countries represented on this map. So as you can see, we had a fairly good representation of parts of the world where you do not have data in from before itself. Here's the characteristics of the participating centers divided by high income, upper middle income, and low middle income countries. Since we had few patients from the low and low middle income countries, we combined these, and these are the number of centers which participated and provided data in this. And you can see here's the regions, and all represented. These are the 10 regions that the International Society of Nephrology, and you can see that the contribution is widespread from all of these areas itself. Most of these patients were derived from cities which were larger cities. And I think this represents obviously one of the difficulties in doing analysis and surveys like this, where the people who have the opportunity to participate are largely based in larger cities. And it also reflects the fact that we may not have information truly reflective of community and smaller settings itself. But you can see that the vast majority were also from hospitals and public hospitals. The vast majority of contributors were nephrologists, as can be expected. But we did have both a pediatric component and also people who are intensivists and other specialties contributing to this data set itself. When you look at the outcomes in epidemiology here's we have the number of centers, pediatric were 89, 262 here, the number of patients, and here's the median age. So we have a lot of pediatric information from very young patients itself. And what's more important is that a significant number, at least about 30 to 40% of them, are from ICU. So we capture both ICU and non-ICU patients in this, and you've got hospital-acquired acute kidney injury as a significant component. Now the differences obviously are apparent across the different regions itself, but what is more interesting is when you look at the number of centers and the number of patients, here's the median age in ICU patients and hospital-acquired acute kidney injury, you can see that as you go down this spectrum of the high income to the low and low middle income countries, the number of hospital-acquired acute kidney injury goes down. So the vast majority of the patients who were enrolled in these settings were for community-acquired. That means they came into the hospital with AKI and were addressed at that point, which is by itself a striking issue because when you see also the age, there is a significant difference in terms of there were much younger people coming in from the low and low middle income countries with AKI, and they had obviously more community acquired. Now, where they came from, almost about 20% of these, or a little less than 20% of these were recognized first in the emergency room. Here's the ICU, ward or step-down region, and very few of them in an outpatient setting, as I indicated earlier. So going back to the 5 Rs, when you ask the risk, what were the risk factors that these patients had, you can see here is these are the inherent comorbidities. And what I'd like to point out to you is that one of the comorbidities that we don't think of very often is anemia. And anemia is emerging as a major risk factor for AKI. And therefore, this also showed up quite commonly. Here is the low and low middle income countries, which are higher rate of anemia than in the upper and middle income countries. Most of these patients were recognized based upon their location, and also what their criteria for acute kidney injury diagnosis were basically mostly on creatinine, although some of them were recognized based on oliguria. But what I'd like to point out to you is here's the stage at diagnosis. And when you see the stage of diagnosis, again, there are differences. The people who were in the low and low middle income countries had a much higher stage of AKI at the time of diagnosis, reflecting the fact that they were probably coming in much later for care than those patients who were in the high income countries itself. That reflects one of the areas that we need to think about further. When you look at the etiological factors, what is very important to recognize is that dehydration emerges as a universal etiological factor across all settings. This therefore represents both an opportunity for a modifiable risk factor here, but also shows you that when we look at common features across acute kidney injuries, regardless of the setting, we may have an opportunity to make a difference if we focus on what is modifiable in that setting. Here's the number of additional organ failures, and surprisingly, even though we are used to seeing patients with multi-organ failure, almost half the patients in this category had only the kidney as an organ failure itself, and you can see that's represented here. Not too different across the regions and in the income settings itself. Most of these patients had more than one contributory factor, in fact 2 to 3 to 4, which is what we generally see. So the multifactorial contributions obviously make a difference. In terms of what was done to these patients, not very different across the various regions. Almost every one of them got fluids, diuretics, antibiotics, vasopressors in different frequencies. What's interesting, though, is that the frequency of biopsy diagnosis in this group is very low. Less than 5% of the patients were biopsied, but when they were biopsied, most of them did not have acute tubular necrosis. They had other features. This reflects, therefore, an opportunity and also a clear area for us to think about is that we must not ignore the fact that histology is an important component in managing these patients, yet we don't do it often enough in that setting. What about dialysis? Surprising to us, peritoneal dialysis was infrequently used, even though that was generally available in some of these centers. Intermittent dialysis was more commonly used, as was CRRT. And one of the things we asked for is how many patients required but did not get dialysis, and you can see here is that in those patients who did not get dialysis, patients in the low middle income countries, which is this category 3, did not get dialysis, they could not afford therapy, or there was no available resources. So therefore, this lends back into the construct that maybe the prevention here might be by providing access to care. What happened to these patients? 7-day mortality was 11%. That is pretty high if you think about it. For a disease in 1 week to kill off more than 10% of your patient population, and the incremental mortality downstream of about 40% is quite an area of concern. And when you look at the pediatric population, what we find is that in the low middle income countries, pediatric mortality was 21%, in contrast to 1.4% in upper middle income countries. So a big difference overall in that setting. And when you look at a logistic regression model for what predicts mortality, you can see here is the fact that you have hospital-acquired kidney injury, the number of organ failures, sepsis, and all these other features play into role. And when you see here's the multivariate analysis, these remain as areas of concern itself. Renal recovery in the high income and upper middle income countries was variable depending upon what the underlying CKD status was, and again representative only at 1 week, so this may not truly represent the overall consequence of this injury itself. And most of these patients in the low middle income countries went home. In contrast, most of them in the upper middle income countries stayed in the hospital or went to a rehab facility, again showing you the differences which are inherent. Just to put this in perspective, on this left panel is a typical case enrolled from Canada. You can see this patient had cardiogenic shock, required a CRT, was managed with CRT, ended up staying in the hospital for 18 days, and ended up going home with 3 months follow-up. In contrast, this patient from India came in with a snake bite And with the snake bite, he presents with a creatinine of 11, a blood urine nitrogen of 230, and he's managed by PD on presentation, has an outcome of 7 days post-AKI, and his length of stay is 12 days. Two very different, very competing, and very different settings, yet the consequence is the same as AKI, and yet the outcome is managed very differently depending upon what happens and what's available. So to summarize what I've shown you, only 2/3 cases were community acquired, 30% seen in emergency room. 2/3 had recognized risk factors, lower comorbidities, and modifiable risk factors. The most common causes were hypotension, shock, and dehydration, and over half of them had kidney as the only organ involved. Urinalysis, renal ultrasound was done in the majority, biopsy was infrequent, 20% needed dialysis, PD was underutilized, and 25% who needed dialysis did not receive it were due to either futility in high-income countries or for lack of resources in the low-middle-income countries. 11% overall mortality, and 2/3 with partial or complete recovery. 1/3 of the patients were not managed by nephrology itself. Now, there are several limitations to this. Obviously, it was predominantly hospital-based settings, larger cities, majority of nephrologists, and the outcomes were limited to 7 days. So we do not truly have a complete picture, which also represents the fact that we need to do more. And that's where we are headed with our next steps on this. First of all, we want to continue to build the research base and evidence for this so that we can convince and raise awareness amongst everybody, including the caregivers, the physician group, and the public, and then have a plan of action for this. So we proposed and printed this in the Lancet in 2015, an overall strategy of how to go about 0 by 25, and this is available freely online. And then we published earlier this year in April the results of the global snapshot, which I've just shown you, and you can look at yourself. What we are now planning to do is obviously garnish further support. As you can see here, multiple societies, multiple industry supporters have partnered with us, and we continue to seek further support for this initiative as we go forward. And what we are now doing is in the process of implementing an intervention study. This is going to be done in 4 regions in the world, in Bolivia, in Nepal, in Malawi, and Tanzania. And where the structure is that we are considering patients in a cluster where there are 3 to 4 health centers out in the community. Those health centers will be equipped with a point-of-care test, and we will observe and see what happens to patients with acute kidney injury in an initial observation phase. And then in an intervention phase, we will provide teleconsultation using a mobile technology through a hospital-based nephrologist in a district hospital in the region who will guide the management, but not necessarily provide the management. We hope to demonstrate this with this feasibility that this is possible to do. And we would compare the outcomes of AKI patients before and after, and we would also establish this as a broader network to do. So this project outline is now underway. It is being reviewed by the ethics committees, and we hope to launch it in August of this year, and hopefully have results available for the World Congress of Nephrology in Mexico City in April next year. We also are seeking and collecting and collating educational tools which can be made publicly available to everybody in the world. So that's the one way for us to raise awareness of this disease and have it available for everybody to look at. So I've gone through a lot of data in a short period of time, but none of this would have been possible without the contributions of multiple people who participated in this and continue to support the initiative, and particularly people in my own group in the San Diego team. So I would end here, and thank you for your attention. And if you need more information, please do contact us through this website. Thank you.